Good evening, everybody. We're just waiting a few moments for everybody to join, but welcome to our webinar on urinary incontinence and pelvic organ prolapse. My name's Jan, and I'm the clinical nurse specialist in continence care here at Benenden. And I'm joined tonight by our presenter, Mr. Abhishek Gupta, consultant urogynaecologist. This presentation will be followed by question and answer session. If you'd like to ask any questions during or after the presentation, you can do so by using the Q&A icon, which is at the bottom of your screen. And this can be done with or without giving your name. Please note that this session is being recorded if you do provide your name. If you would like to book a consultation, we'll provide details for that at the end of the session.
Evening, everyone. My name is Abhishek Gupta. I'm one of the consultant gynecologists, and I'm a urogynecologist. I did my training in Southeast London. So I started training from Guy's and St. Thomas's and then rotated in Southeast London. And during the process of my training in gynecology, I did my specialized training in incontinence and prolapse. And also I have special interest in doing keyhole surgery. And in my NHS base in Darren Valley Hospital, and I have started also offering robotic surgery in Darren Valley Hospital last year. I'm an active member of British Society of Urogynaecology. I was for 6 years in their governance committee. And I also am a member of Royal College of Obstetrician Gynaecologists and a member of British Irish Association of Robotic Surgeons. So that's me.
Thank you. And I'm Jan. I've been working in urogynaecology for at least 20 years now, and I manage the specialist nurse team here at Benenden. And we're really lucky we have 4 specialist urology nurses here. We run nurse-led clinics that I'll tell you a little bit more about later, and we also offer urodynamic assessments. So
in this session, what we have tried to include is what urogynaecology is, then what overactive bladder is, what stress incontinence, then and I can't stress enough that the incontinence, prolapse, and issues with pelvic floor and waterworks, it is joined up approach with the specialized nurses, and they're so important for assessment, so important for your primary treatment, and also if you do have to have any surgery, it's so important for the post-op care and all the investigation that nurses do. Then we'll talk about a bit of a pelvic organ prolapse, and we will also point to you about where you can access some resources which you can read, and then if you have any questions, you can post it on, and then we'll try to take as many questions as possible towards the end of our session. So what is urogynecology? So that's an area of gynecology where we dedicate in treating pelvic floor dysfunction, which is mainly urinary incontinence, prolapses. The common referrals we get is incontinence, prolapse. Some patients come with recurrent urinary tract infection. Some people have pain when the bladder is full, and then also the injuries of childbirth, which can cause various issues. And obviously, for us to practice in urogynecology, we should have gone through the specialized training in this area before we become consultants, and then we practice. So it's quite a governed field. So people doing urogynecology, which is prolapse incontinence, they have to have specialized training. We all have we all associated with British Society of Urogynaecology. So all our operations and their outcomes should be recorded in the database. And any patient who is having any surgery with us should be discussed in our central multidisciplinary team meeting before we offer surgery. So it's quite a regulated area now, more so after the mesh debacle, which happened, and the report came out in 2019. So more so, it's quite regulated and quite a specialized area now. So these are the common referrals we get. So obviously, you can guess that we get a lot of bladder problems. Then we also get fair referrals for vaginal prolapses. then UTIs, bladder pain, and post-childbirth injuries. I'll talk a bit more about health. Let Jan talk about a bit of more healthy bladder.
Lovely, thank you. Yeah, a lot of the things we talk about with in the nurse-led clinics, we talk about healthy bladder. So actually, what is a healthy bladder? So basically, you should be drinking between 1.5 and 2 litres a day, with no more maybe than 2 to 3 caffeinated drinks. If you're drinking that amount, you should be emptying your bladder about 7 to 8 times during the day, roughly around every 3 hours. Nighttime symptoms, so nocturia. As you get older, you're going to be getting up a little bit more at night, but ideally it shouldn't be any more than once. So if you're looking at that and thinking, oh, I go to the toilet more often than that, it may be, but you would benefit from a specialist nurse assessment. On the right-hand side of the screen, you've got like the colours of urine. So your urine should be straw coloured. It should be infection free. So if you have an infection, it will be cloudy, may have a little bit of an odour. So you want your urine to be straw coloured. If it's darker, that's suggesting that you're not drinking enough. And again, that's going to put you at risk of urine infections.
So first and foremost, now we'll talk about the urinary issues. So one common thing we get is urgency of waterworks, or people needing to go to waterworks often, and also complaining that they get up in the night few times to empty the bladder. Now, this is called frequency, urgency, and getting up in the night is called nocturia. So these are the common presentation which we get. And what happens to the typically patients who have got overactivity of the bladder, what we mean with overactivity is, if a normal bladder, if you feel that you need to go for urge to go for passing urine, then in a normal circumstances, if it's not too full, you can hold. You will find obviously a toilet nearby, and once you find a safe space where you can empty the bladder, your nervous system kicks in, you relax your pelvic floor, and then you empty the bladder. The people who have an overactive bladder, typically the bladder is trying to contract without their will, against their will. So once the bladder starts to contract, you feel that sense of contraction, and even if you want to relax the bladder, you're not able to, and hence you keep rushing to the toilet all the time because the bladder is doing this for you. And also sometimes the bladder contraction, if you imagine the balloon, if the bladder contraction goes, if the balloon squeezes completely, then even if you don't want to, if you want to hold this urine, the balloon is squeezing that water out, and then your pelvic floor will not be able to hold, or your bladder sphincter will not be able to hold, and you start leaking. This is called urge incontinence, which we say is a symptom of overactive bladder. Now, why this happens? Most of the time we don't know why the overactivity of the bladder has happened, and we have seen overactive bladder at all the ages. However, it is more prominent as people get older. So they have less, your bladder holds a bit lesser, they becomes more overactive, and then you can to go for frequency and urgency of waterworks often. Sometimes if you have recurrent urinary tract infections, that can cause your bladder to become overactive. Not so much in female, more so in male, but if there is any blockage which makes you not go for waterworks that well, like if you have got a massive prolapse, then you may notice that your overactivity of the bladder is more. And some neurological conditions. For example, if you have an MS, then there is a nerve loop which kicks in, and your bladder, the nerve is constantly asking your bladder to contract, and you leak. You will also find that the patients or anyone who drinks a lot of caffeinated drink, smoking, or take fizzy drinks and alcohol, that can irritate the bladder quite a bit, and that may make you often feel full, and you often need to go for waterworks often. So that's kind of a lot of things which causes overactivity of the bladder, and it typically presents with symptoms of, obviously, as I said, urgency, so need to rush for the toilet. You can get more often you may have to go for waterworks, and sometimes you leak because if it's your bladder is contracted so much that your balloon can't hold, then you leak, and sometimes you'll have to get up in the night few times, which is called nocturia. typical overactive bladder patients who got overactivity of the bladder, which kind of really affects their quality of life, usually have small volumes of water. So when they go for passing urine, they only pass a small amount because the bladder is full with a small amount, and the bladder is constantly in that situation. So small amount of water goes in. You pass a small amount of water and more often. That's typical of overactive bladder. And sometimes you get lock and key effect. You need to go for waterworks. You put the key in the house and you start leaking. That's a typical symptoms of overactive bladder. You find sound of water if you're doing washings, putting your hand in the water and you suddenly have the reflex, which makes your bladder contract. So that's again typical overactive bladder. So these are kind of telltale sign of typical overactive bladder causing you urgency and urgent incontinence. So what are the management options? It's all about quality of life. So nothing we're going to discuss today, which is anything else but the quality of life. And it's important for caffeine reduction. So if you drink a lot of caffeine, tea, coffee, make it decaffeinated. Healthy intake of fluid is 1.5 to 2 liters. If you're getting up quite a few times in the night, but you take a cup of tea or cup of coffee before you go to bed, or a glass of wine before you go to bed, then you will get up in the night. It's well known that as we all go older, we do have a more sensitivity, and we go to toilet, we wake up in the night for going to toilet. Hence, the fluid management is so important if this is causing you a problem and having you less sleep and getting your sleep disturbed or getting your day-to-day life disturbed. So fluid management is very important. Pelvic floor muscle exercises is again very important. It is helps you to hold your bladder longer. It can also helps to manage your symptoms and your reflexes. We've talked about nocturia, which is getting up in the night. If you feel that you're not emptying the bladder well, sometimes you empty the bladder, then you get up and 5 minutes later you empty it again, so that you know that you are emptying the bladder well completely, so that when you're going out, you know you're going out with a complete empty bladder. And obviously, if you have a tendency to constipation, then straining is not good for your pelvic floor. And obviously, if the first stage treatment, which is bladder retraining, which is where Jan and her team teaches patients how to hold the bladder a bit longer, especially when you're at home, so you don't have a fear of leaking in public. And that helps to improve your capacity of the bladder longer, and also reduces how many times you go for waterworks. If those things don't work, then we go into the next step of treating your symptoms with medication or getting more specialized tests. So what are the medications which we can offer? So one is called anticholinergic. So there are two main medications which are used in overactive bladder. One is called anticholinergics, and one is commonly called mirabagrone or Betmiga. So anticholinergics have got various trade names: oxybutynin, tolterodine, solifenacin. So what they do is they work on a receptor on the bladder to prevent the contraction. So this medication prevents the contraction of the bladder. And the Betmiga or mirabagrone works slightly differently. It helps to relax the bladder. So one is preventing the contraction, one is relaxing the bladder. Hence, the side effect profile is different. So the anticholinergic medication can give you a lot of dry mouth because they're the same receptors which are used to produce mucus. It can give you palpitation. And because it reduces the contraction, sometimes it can also give you a lot of constipation. So that's the common side effects people get with anticholinergic. With Betmiga, it is better tolerated because it's got less of side effect because it works with relaxation of the muscles. So if patients come with urgency, frequency, nocturia, first step is to go and get your fluid management. So you'll be given a bladder diary. You'll go and see Jan and team to assess your pelvic floor. I mean, we assess in the clinic, then Jan and Mary and the team will assess the pelvic floor as well. Go to the bladder retraining, fluid management, and we may trial the medication for you as well. If your symptoms get better, we do nothing. And if your symptoms don't get better, then we do a specialized test called urodynamics, which we'll talk in a minute, which is a physiological test of how your bladder is functioning. And then we go with more invasive treatment. So the more invasive treatment for overactive bladder, which the one we offer at Benetton is called Botox treatment. So what Botox does is it's a very simple procedure. we have a quick look inside the bladder with the camera and give an injection of Botox in the bladder. And the little picture on the slide is to say how the Botox is given. It's spread over the bladder. So what it does, it relaxes the muscles quite well. So patients who really their quality of life is suffering because of overactive bladder, they have to keep going to the toilet, they keep having urge, they keep leaking. Once they've exhausted the medication option, if they don't get better, then Botox has really helped with their quality of life. The only two flip side with Botox is it needs repeating. So every 6 months to 2 years, you will find that the symptoms coming back and we may have to repeat it. Second, with the Botox, sometimes your bladder relaxes so much that you're not able to empty the bladder well. So 1 in 12 women, we have to teach how to catheterize, or Jan and team teaches how to catheterize the patients in case the need arises after the procedure. That's the flip side with Botox. The other two options, one is called percutaneous tibial nerve stimulation, which is called PTNS. It is like stimulating the nerves by doing a slightly equivalent to acupuncture, which also can help with your bladder symptoms. At least it's less invasive. And Jan does offer PTNS here. Sacral neuromodulation is slightly more invasive, where they put a little electrode on your back, which then regulates the bladder contraction and reduces your chance of urgency and bladder going contraction. PTNS is a good option, but the PTNS is at the moment available only in the tertiary centers. And for that, the patient will have to refer to tertiary center like UCLH to get the PTNS option for a nerve modulator to put on the spines on the back. Anything I've missed?
No, that's fine.
Okay, so the other thing which we get with incontinence is stress incontinence. And quite often we get mixed pictures. Patient may have both overactive as well as stress. So quite often we get sometimes mixed picture. So stress incontinence is slightly different. Now, what is stress incontinence? If you imagine you got bladder, which I'm again saying is a balloon because bladder is like a balloon with full of water. Now, if you imagine my wrist as a balloon, and the tube which drains water out is like a urethra. Now, when you cough, sneeze, laugh, run, trampoline, shout, or do any exercise, which increases the tummy pressure, and as you can see on our slide as well, when the tummy pressure increases, the pressure is going on this balloon to get you to leak urine, because that's the same pressure coughing, sneezing, running. So the balloon is trying to obviously leak. But when you had good muscles in the vaginal area, just at the neck of the bladder, the same pressure comes from the top to the urethra, and same pressure is counter pressure is through the vagina. So with the receptor, with your pressure from the top, pressure from the bottom, the tube which drains water out can close, and hence you don't leak. When you don't have much support at the neck of the bladder level, the tube which drains water out, which is called urethra, doesn't, when you cough, sneeze, or lift water, it doesn't close. It just kinks because there's no counter support at the vaginal level. So the hose pipe doesn't close. It just kinks. So you've got enough space for urine to leak. And that's what the stress incontinence happens in a patient. Well, and what are the risk factors for stress incontinence? Obviously, anything which has a trauma to pelvic floor can cause stress incontinence. So obviously vaginal deliveries, and more than vaginal deliveries, if you have instrumental delivery like forceps or venous delivery, they do cause a lot of trauma to pelvic floor. Then menopause. Okay, so when the woman body hits menopause, the menopause itself doesn't cause stress incontinence, but it can cause a weakness in the vaginal area and the support tissue, and then it can lead to have an increased symptom of urinary incontinence. Obesity, if you've got a lot of weight you carry around the middle, it will put a lot of pressure on the pelvic floor. It does causes increased leak, and it does reduces your success rate of any surgical, if you offer any surgical correction. Obesity does reduce your success rate and increase your complication. So it's so important to manage weight before we attempt any incontinence surgeries in future for getting you the best outcomes. Age, as we unfortunately all of us go older, we don't go younger, and with age the supportive structures do fail, and it can cause more susceptibility of leakage. Smoking and chronic cough, they can do two things. One, it does weaken your pelvic floor. If you keep coughing, you do weaken your pelvic floor because the excess goes through the pelvic floor. Smokers tend to have more um, weak pelvic floor or any muscle tissue or connective tissues. And even if you have a surgery, the smokers heal up don't heal up that well as the non-smokers. So smoking cessation is so important. And obviously, if you got a neurological disorder, and the last, which is prostatectomy, doesn't hold us, but this is more for male than female. So this kind of issues are more pertaining, and genetic plays a part on a certain cohort as well, because the collagen, which is a tissue which holds, or your connective tissue, some of the collagen deficiency can be genetically linked, and that can also make you more susceptible for both prolapse as well as incontinence. So what is the treatment of stress incontinence? So first and foremost, the treatment of stress incontinence is again pelvic floor exercises. So reduction of smoking, or preferably stopping, pelvic floor exercises, and managing your weight. This is the really first line treatment of any urinary issue or a prolapse issue you have. Now, it's all about quality of life. How often you leak, how is that quality of life is different. And remember, it's about your quality of life. It's not about your neighbor's quality of life. It's not about your sister's quality of life or your mom's quality of life, because everybody's quality of life is different. If a young woman who's 30 years old, have got 2 children, who goes trampoline with those kids and leak, her quality of life is disturbed because of she wants to do more activity with their children, than someone who don't do that much of activity but leak very less, but they can manage their leakage without it affecting quality of life. So everybody's quality of life is different. Is the prolapse or incontinence, what is it causing to you, and what is it stopping you doing? So it's all about quality of life. So once the pelvic floor exercises we have done, weight loss we have recommended, things have not worked, it's affecting quality of life, then we default again to the test of urodynamics, which we'll talk in a minute. When the urodynamic is done, it's called 3 purposes urodynamic test. One is to give us the diagnosis. So it differentiates whether you got stress incontinence, you got overactive bladder, because treatment are different, or you got mixed picture. How is your bladder? What is your capacity of the bladder? How you're emptying the bladder? It helps us to counsel. So diagnosis, capacity, and how you're emptying the bladder. That's the 3 things which this test tells us, and then we can plan your treatment. So if we have now, you got stress incontinence, we have exhausted, this is now affecting quality of life, pelvic floor exercises have not worked, then what are our options? So now we're going to the 3 options we have for stress incontinence. One is called Bulkamid, which is a urethral bulking agent. It's a local anesthetic procedure, and I'll talk to you more about in my next slide. And there are 2 surgical options. One is called autologous rectus fascial sling surgery, and last is a colpus suspension surgery. So 2 surgical options and 1 Bulkamid, which is least invasive option and it can be done in local anesthetic. So what is Bulkamid? So how do we do it? So Bulkamid is a procedure where it can be done in local anesthetic. Obviously, you have a choice of general anesthetic if you want to, but majority of my patients tolerate this procedure very well with local anesthetic. So what we do is, in our ambulatory care unit, we give you local anesthetic injection just next to urethra in the vagina, and with a camera at the neck of the bladder level, you can see 4 sides. We put this injectables, which is a permanent gel. What it does is it gives you support at the neck of the bladder level and reduces the leaking. So the advantage is it's the least invasive option, and it's a permanent gel, and sometimes we may have to repeat it. And when you have to repeat it, I only repeat it once or top it up. It works on around 60% of the patients. 60% of the patients, it's all about quality of life, as I was saying. 60% of patients feel that quality of life is better. There's not much downtime with this procedure, so you can go home same day, and you can go into the normal activities pretty much from same day or next day. What we tell patients to do is we ask them to avoid sexual intercourse for around 3 to 4 weeks and a high impact strenuous exercises after that procedure. Otherwise, you are allowed to do everything. So it's a least invasive option, but works on around 60% of the patients and may need a top-up or repeating once if we have to do it. The rest two surgeries, one called autologous rectus fascial sling. So what this does is it's a major surgery. It's 80 to 85% successful, where we give a bikini cut incision, take something called a rectus sheath out of your body, go through the vagina, and again stitch it up. So that holds and forms a hammock just near your neck of the bladder or through the vagina, and it forms the support there. So this is called rectus fascial sling. It works well, 80-85% success rate, but it is also a major operation which requires 6 to 8 weeks recovery period and a hospital stay of 1 to 10 days. And sometimes the bladder, sometimes after the procedure, you feel that you're not emptying the bladder very well. And it can happen in roughly around 1 in 10 patients. And we do teach you how to catheterize yourself before we do this operation, just in case the need arises. And the last option is called corpus suspension, which is again a very good surgery. It's 80 to 85% success rate. And what we do, again, rather than taking any tissue out from your body, we give a little bikini cut incision, go deep in the vagina, to the stitches next to the neck of the bladder, but through here, and hoik it to the bone there. So it lifts the pelvic floor up like this. Again, 80 to 85% success rate, and since 6 to 8 week recovery period. We still teach you how to catheterize yourself in case need arises, but in our experience from the patients, we are seeing less issues with the catheters with corpus suspension than fascial slings. And corpus suspension can be done open, it can be done keyhole, and in my NHS base, I do it robotically, because this place, which is the pelvic, just behind your pubic bone, is quite a small, narrow place to operate on. So robot does give you a better vision, but it can be also, we do offer it routinely here open. So it's corpus suspension. So that's the 3 options you have for stress incontinence: Bulkamid, fascial sling, and corpus suspension. Okay, I'll pass it on to Jan for some.
Lovely, thank you. So just going to talk a little bit about specialist nurse assessment. So if you're listening to this and you're thinking, oh, I might have those symptoms, or am I doing my pelvic floor correctly? You can get an appointment just directly with us. You don't necessarily need to have seen a consultant first. And a lot of the time, if your GP referral is mentioning incontinence or mild prolapse, you probably are going to see us as a first line anyway before we refer on to the consultants. So we're going to sort of take up a history. We want to know a little bit your background, your medical history, but we want to know about your symptoms and what bothers you. And I think, as Mr. Gupta was saying, it's all about individual quality of life. It's not for me to say, oh, you've got a large prolapse or you've got stress incontinence. It's what bothers you, and that's what we're going to focus on. We're going to test your urine to make sure you haven't got an infection, and we'll just do a small bladder scan to check that you are emptying your bladder properly. We'll get you to fill in a bladder diary before you come along. That's going to be for 3 days. You record what you drink, and then you measure and record how much urine you're passing. So if you've got something like overactive bladder, you might be emptying your bladder quite frequently with small volumes. If you've got stress incontinence, you may have good, nice, regular emptying every sort of 3-4 hours, but there's going to be ticks on there for when you're leaking. And we'll give you advice about your drinking. So that might be restricting on your coffee, restricting your intake if you're drinking sort of more than about the 2 litres, maybe 2.5, if you're exercising or you're being more active. And one of the key things there, particularly sort of from an overactive bladder point of view, is looking at the bladder retraining. And what happens with your bladder, as Mr. Gupta said, you get that first sensation that your bladder's filling, but that doesn't always mean that you need to go then. That's just your bladder saying, oh, I'm filling, I might need to go in a minute. So you've got time to finish the ironing and then you can go afterwards. With overactivity, you lose that, oh, I'll go in a minute, and it's, I have to go and I have to go now. So we'll work with you on actually how can we retrain your bladder? How can we extend that interval of how often you're going? And the key thing for whether it's stress incontinence, prolapse, overactive bladder is going to be about pelvic floor exercises. We'll assess your pelvic floor, so that's going to involve just a little vaginal assessment, because that's the only way that we're going to know that you're doing your pelvic floor properly. We don't want to give you exercises and you've gone away and not done them quite right and we haven't improved your symptoms. We'll look at your bowel management as well. If constipation's an issue, difficulty emptying might be an issue if you've got a rectocele. Mr. Gupta will talk about that in a while. We'll help you with weight loss, and we'll give you advice about the exercises that you can be doing, particularly to things like Pilates, that can also help with pelvic floor muscle strength. As we've said, one of the sort of the key things for all of this is going to be pelvic floor exercises. So with pelvic floor exercises, you do strong contractions, you do fast contractions. And I think the key thing to remember is it's going to take at least 3 months to strengthen up your pelvic floor muscle. There can be that tendency to do them for a month, things aren't really a lot better, so you can give up. You absolutely have to carry on with them. In most people, you will get some improvement. It might only be slight, and it might not be enough to give you an improvement significantly in your quality of life, and you might then need further interventions. But actually, then that's going to get you in good stead, you know, to recover from your surgery. So to strengthen your pelvic floor muscles, it's about squeezing the muscles underneath, gently squeezing as if you feel you're trying to stop passing wind, and also squeezing to feel you're trying to stop emptying your bladder, passing urine. And what you do is you squeeze that muscle up for a count of 1 and you relax it for a count of 1. That's what you call the fast contractions. Not fast really quickly. Make sure you feel you've squeezed for 1, relaxed for 1, and do 10 of those 2-3 times a day. They're very good, or that's the main exercise for the stress incontinence. The strong contractions, squeezing and holding, you're going to need those if you're trying to work on your bladder retraining. You're going to need those to give you support for prolapse, and that's about squeezing and holding. And it may be that actually you can only squeeze and hold that for 3 or 4 seconds, but that's fine. Do that, relax it down, try and repeat it 5 times. Do that 2 or 3 times during the day. Really importantly, when you're doing pelvic floor exercises, don't hold your breath. Don't tighten your stomach. All of the work should be going underneath. So what you're trying to feel is almost like a slight lifting feeling in the vagina. Yeah. Thank you. Yeah. So Mr. Gupta mentioned urodynamics study, which is a bit of a pressure test on your bladder. So if we've done all of the conservative interventions and you're still symptomatic, we'll do this. A urodynamic study involves having a little catheter put into your bladder, attached to a bag of fluid that's going to fill your bladder up artificially. You have all normal sensations, so you might be saying, oh, actually, I've got a lot of urgency now. Or if you get stress incontinence, we'll have you coughing at the end to try to make you leak. But it's going to give us a graph printout, and it's going to give us a diagnosis. It's going to show, have you got a stable bladder or have you got an overactive bladder? When you cough, are you leaking? So we're going to sort of give a report of everything we've got from the test, which helps as a diagnostic tool for Mr. Gupta.
So if we gone down the route of urodynamics, which is a kind of, as Jan was saying, it takes you have to put a catheter in the bladder, a small catheter in the back passage to see how your bladder is actually behaving. That means the conservative options and the medical treatment has not worked. So now the whole idea is to get the diagnosis confirmed and so see how physiologically your bladder is working, and then we're thinking about going down the route of invasive treatment. So there's no other role for urodynamics to get the diagnosis when we started thinking about doing something more invasive. Mm-hmm. So I think we covered the incontinence topic a bit. Now we'll try to cover some prolapse as well. So what is basically the prolapse? So hopefully my cursor moves so you can see. So it's a 2-dimensional picture. So we're looking at the woman from front to back. So first thing you notice is a bladder. which drains water out, which is called urethra. And when we were looking at the slide to bulkamid, we were putting bulkamid somewhere there. So this is bladder, neck of the bladder, urethra. That's vagina. That's womb. That's neck of the womb, and that's the back wall, back passage. So that is human anatomy. And the prolapse is basically herniation of your organs through the vagina. And herniation happens because of the weakness of the support structure. So when the support structure weaks, it gets herniated. So the support structure here are the ligaments which hold the womb. The support structure here for the bladder is the fascia here. This is levator ani muscle, which is again a support structure. And then you got support structure here for the bowel, which is again called fascia and the levator ani muscles. So anything which can cause the weakness of tissues that can cause you to have prolapse. And then again, as we were discussing with incontinence, some things are overlapping, like trauma from a childbirth, instrumental delivery, chronic cough, lifting heavy weights, previous pelvic surgery, age, previous hysterectomy can cause weakness in the tissues. Then we talked about obesity. We talked about smoking. Again, we talked about genetic causes, where we genetic causes, which is where the collagen tissues are weak, like Ehlers-Danlos syndrome or something else, where you are born with the congenitally weak tissues, and that can increase your susceptibility of prolapse and incontinence. So this is what usually causes the prolapse. But prolapse can happen on patients who have never given birth as well. With age and with connective tissue disorder, it can happen. So that's the normal anatomy we were talking about. That's the bladder, womb, vagina, urethra, back wall, and anus. So what are there are three compartments in the vaginal area. The front wall is middle, and the back wall. So when the bladder starts to descend into the vagina, which is the weakness of this front wall, then this is called cystocele, where the bladder is coming down. And obviously, I'll just ask you to have a look here. What's happening with the urethra? It's getting kinked. So this can present as bulge. So people do present bulge. They find it very difficult to empty. Sometimes they find if it's a big cystocele, you can find it difficult to empty the bladder. You find that you have slow flow, and you find it difficult to empty because rather than urine going here, it goes here. So you might have to double void to completely empty this. And sometimes if you're not emptying the bladder well with a significant cystocele, you can also present with recurrent urinary tract infection because it acts as a reservoir. Similarly, if it goes on the back wall, it's called rectocele, which is the prolapse on the back wall of the vagina, which is the bowel pushing in. It can again present with bulge, uncomfortable feeling, and also sometimes it doesn't cause you constipation, but if the bowel is full and you're unable to empty, sometimes you might have to splint or push through the vagina, which creates a little pocket here. So you're not able to empty the bowel well. So sometimes you can splint to empty the bowel. And the middle compartment, i.e. the womb, can come down, which usually presents as a discomfort and pressure and the bulge. And if patients had hysterectomy, you still have the top of the vagina, and the top vagina can come out, which is called vault prolapse. So these are the common causes of the common prolapse. The front wall is cystocele, back wall rectocele, middle is either a womb prolapse or the prolapse of the top of the vagina. The prolapse and discomfort usually gets better if you're resting. So if you're at the night and you're resting and you're sleeping and you don't have a discomfort, if you're on your feet for a long time and you feel your prolapse is worse towards the end of the day, that's gravity. So typically prolapse presents like this. Again, having a bit of prolapse after childbirth is common. So you might go to your GP for a smear test, and the GP says, or GP practice, a specialist nurse tells you, got a bit of prolapse, but if it's not causing you any problem, you're not feeling dragging, you're not feeling bulge, you're emptying your bladder well, you're emptying your bowel fairly well, then that prolapse doesn't need specialized treatment. All it needs is a pelvic floor exercises, because it's all about quality of life. So never do an operation on a prolapse if it's not affecting quality of life, thinking it may get worse in future, because it may never get worse in future. And all prolapse treatment has 1 to 3 in 10 chance of prolapses coming back. And doing the first time around in a prolapse operation is always the best. Having a repeat operation increases the complication, reduces the success rate. Hence, the quality of life discussions come very important. So what is the treatment for pelvic organ prolapse? The treatment of pelvic organ prolapse is all about quality of life. So as we discussed first, the pelvic floor exercises and the lifestyle changes with weight loss, cessation of smoking, doing pelvic floor exercises, avoid lifting heavy weight, avoiding constipation is so important. If that helps your quality of life, we don't have to do anything else. If that doesn't help, then we go next step. Hormonal treatments don't sort your problem of prolapse out. And it's not the systemic hormone doesn't help with prolapse. The only thing which can help with prolapse, and it takes your symptoms away, is a condition called vulvovaginal atrophy, which is lack of estrogen in the vaginal area when the skin loses a lot of water and becomes very thin. And it can get a lot of dragging and a lot of feeling of discomfort. And obviously, if you're having pelvic floor exercises or even having surgery, reversing vulvovaginal atrophy does help to make you feel comfortable, reduce the risk of infection, helps you to heal better, and helps you to do better pelvic floor exercises. It does make your skin and your condition better. And it can be helped by taking local estrogen, not systemic estrogen, not through the oral, not through patches, a cream or a pessary via vagina, which is a small dose of hormone, which works vaginally. The amount which comes in your bloodstream is little, so it doesn't give you any side effects, but works really well. And then before the surgical option, there is an option of pessary device, which comes in various shapes and forms, which is like a ring or a donut or a gel horn. So what pessary does, it goes in the vagina, and all it does is to support the prolapse. It's not a cure for prolapse. It's just to, and it doesn't prevent it getting worse. All it does is to hold that in place to for you to get better symptomatic correction of prolapse. The advantage is it's less invasive, so you don't have to have an operation. The disadvantage is that it needs to be changed every 4 to 6 months, and it can give you pressure sensation. It does give you some vaginal discharge, and last but not the least, the pessaries work only on 50% of the patients, so it only works in 1 in 2 patients. It doesn't work for everyone. And as I said, it needs to be changed every 4 to 6 months. And then surgery. What is the aim for the... So what are the aim of surgery? Surgical aim is, again, to improve your quality of life. So obviously the prolapse, if you've got bulge, restoration of the organ where they are. So if the bulge is the main issue, we need to operate to make the bulge better. If you're having discomfort, it is to make the discomfort better. It also, sexual activity is very important, people. If it's causing problem with sexual activity, get better. If you're not emptying your bowel well and you have to digitate through the vagina to empty, or splint to improve that, that's your symptom control or how of quality of life improvement. If you're not emptying your bladder well, then we do the procedure to get your bladder well, and it depends on where you have got the prolapse. So if you've got a front wall prolapse where the bladder is coming down, you open this area, push the bladder back in, bring the tissues together and suture this up. We also, if your bowel is coming, we do the same for here. And if the top of the vagina is coming down, if the womb is coming down, then obviously one of the options, which are age-old option, is a vaginal hysterectomy, works really well. And sometimes the alternative vaginal hysterectomy is to restitch the neck of the womb, which is called sacrospinous fixation, which is the same process, same operation, which we can also offer if you already had a hysterectomy and the top of the vagina is coming down. And the last option for the womb prolapse or the top of the vagina prolapse is something called sacrocolpopexy or sacrohysteropexy, which is use of a mesh. And that is done to the tummy. We at Benetton don't do any mesh surgeries. But the mesh is an option. So it depends on where you are prolapse wise, and hence we do the operation. Is usually irrespective whatever you get done, 1 to 2 nights in hospital stay. Complete recovery takes 6 weeks or so. Whatever the stitches we use dissolve themselves. And as I was talking in my talk, there is a chance the prolapse can come back. And also, sometimes you can get pain during intercourse, which is called dyspareunia, which is scar tissue. Usually settles on its own. Occasionally, we may have to divide the scar tissue. And in my previous slide, where I showed you that when you have a cystocele, your urethra is kinked, and you're not able to empty the bladder well at this level here. So if I correct the cystocele, that kink is gone. So it straightens your urethra. So sometimes after repair, it can unmask an underlying problem of leak of waterworks because the kink is causing it. So once we correct it, it can unmask a bit of leak of waterworks. And if it does happen, we may have to do further treatment. So there are pros and cons of every surgery. So hence, if it's affecting quality of life, have the prolapse. And if the choice you want for a surgery, then it's a good time to have the surgery because you want to improve your quality of life. These are some resources. What I would recommend that you go into a British Society of Urogynaecology website. You can Google it up, British Society of Urogynaecology, which is called BSUG, and there is a section for patient information. And you'll get a lot of resources where you can read about operation as well as different options. We have touch base and the physiology of what prolapse and incontinence means. So it's a good resource in one place, which is British Society of Urogynaecology, and then patient information. You just have to Google, you'll go into this page and you can read all of this literature.
Lovely, thank you, Mr. Gupta. I'm going to leave the slide up that talks to you about consultations, but we're now going to go to some questions and answers. So I've got a bit of a double question here. Is incontinence common during menopause, and would HRT help?
I think some of this we have covered in our discussions, Jan. So obviously, as time goes, when we go older, the connective tissues do get weaker. And with lack of hormones, the connective tissues even become more weaker. So yes, the menopause and age can have a contribution to urinary incontinence. But obviously, systemic HRTs, if you start early, systemic HRT is when you take a patch or an oral or a gel. If you start early, then it can improve your connective tissues. But if you have not started just after going into menopause, then there is no evidence that after 5 years or 6 years of menopause, an HRT, systemic HRT will work. However, the local vaginal estrogen can still help and work, and it's less. It's got less side effects as well.
Thank you. I'm fit and healthy, but I discovered I had a prolapse after a long walk. It went back after I rested. So should I be concerned, and should I try to do less?
Yeah. So as I was talking about, the prolapses do get worse towards the end of the day, especially when you're on your feet for a long time because of the effect of gravity. And it's all about quality of life. So if the walking, running is a good form of exercises, and if that is really important for you, and that is important for your quality of life, I wouldn't say that necessarily you have to do less of that. If it was a day when you did a huge 20 miles walk, which was not common for you, and you don't do it often, and that's not your quality of life, then yeah, you can change your quality of life and see whether it helps you. But if it's come down with a normal walking or normal long walk, which you like to do, then that is where I'm saying that is affecting your personal quality of life, and then you should get seen, and we will like to try to help you.
Yeah. And if you try Bulkamid and it doesn't work, could you be worse off?
No, Bulkamid usually either works or doesn't work. So even if you have the Bulkamid, it doesn't work, you can be suitable for any major surgeries in future. I haven't seen Bulkamid causing any issues to patients up till now.
Lovely, thank you. And a question, once I've started to pass urine, I can't stop. Can this be improved with pelvic floor exercises? I think absolutely. we can definitely work on your pelvic floor. A lady has said on our description in the beginning, we mentioned acupuncture for stress incontinence. That would be the PTNS, so the tibial nerve stimulation.
Yeah, it's not for stress.
Sorry, yeah, that's for your overactive bladder, which is something that is offered at Benedon, but not the acupuncture isn't for the stress incontinence. Our lady's put on here that actually she's doing pelvic floor exercises, but she has a tense pelvic floor. And pelvic floor exercises don't really help. So again, I think a specialist nurse appointment, we can look at pelvic floor relaxation, pelvic floor massage. So if that's something you're interested in, you could come and see the specialist nurses or come to see Mr. Gupta just for a consultation.
It's also important to see that you're doing it well. So I think pelvic floor exercise is one of those where it's easier said than done. So it's good to know whether you've been able to contract those muscles. And sometimes people overdo it as well with the wrong way, which doesn't help. It's always wise to see a specialized physio, see one of the continence care specialists to see what's going on.
Yeah, what's going on. And again, a bit about exercise. Can I do aqua aerobics, yoga and Pilates with a vaginal prolapse? We would definitely say, yes, you can do all of those. I think the things to avoid if you have prolapse is going to be doing things like squats. Don't do abdominal crunches. So don't do things like a rowing machine. Be cautious on cross trainers. But otherwise, as I say, a lot of exercises will help to support your pelvic floor as well. What is a stage 4 prolapse?
Yeah, so there are 4 stages of the prolapse. One is so if you look into the whole vaginal length, when the prolapse starts to come down to vaginal length and it's reached the 50% of vagina but not coming out of your body, that's stage 1. When it's reached the 50% but just started to coming out of your body or vaginal opening, from there to there is stage 2. When it starts to come out of your body is stage 3. And when in a crude way, when everything has come out, it's stage 4.
Thank you. I have prolapse. Sorry, excuse me. I have prolapse, don't want surgery, but haven't been offered pessaries. It may just be you need to go back to your GP, or some GPs don't fit pessaries. So again, I think coming for a consultation and some advice here at Benedon would be.
It also depends on your how's your muscles of that area, because as I said, pessaries only work on 50% of the patients. So if your pelvic floor muscles are quite weak, and sometimes some of the prolapses are not suitable for pessary device, so it's when we examine, we get a bit of idea whether this prolapse will the pessary will work on you or not. So it will be only after examination one can give an opinion whether pessary can be tried or not.
And can you use vaginal HRT pre-menopause?
You can, but at the end of the day, if you're not gone into menopause, you shouldn't have any issues with vulvovaginal atrophy or lack of hormone in the vaginal area. So, if you're getting regular periods and not got into menopause, you should have enough of your own estrogen to not cause lack of estrogen in the vaginal area. Sometimes we have to, if it's too much of vaginal dryness, but it's usually we examine you to make sure there's nothing else going on before we recommend that to be done.
Yeah. And is a vaginal hysterectomy suitable for all patients, including elderly?
I think nowadays with advances in anesthetic and post-op care, if the womb is coming down and you're fairly okay with your fitness for surgery, then we do offer vaginal hysterectomy for different age group as well as for 80 plus. We have, even in Benedon, we have done quite significant numbers of vaginal hysterectomy on patients who are 80 plus. Obviously, if you require any post-operative care for high dependency unit or ITU because of a lot of comorbidities, then it can still be done. But we will like to do it in a place where you have an HD facility rather than in Benedon. But routinely, we do offer 80 plus patients if they want hysterectomy to be done.
Yeah. Does it help to use, it says here, a vaginal TENS machine? So obviously like pelvic floor muscle stimulators. I mean, I think there is a place for those. I think you need a really good assessment of your pelvic floor with a specialist nurse first, and it's you doing the exercises that's really important. But if you're using sort of a pelvic floor at the stimulator machine, it would be doing your pelvic floor exercises alongside. It's not going to be an alternative, and I don't think it's a quick fix. A lady's mentioning that she's got urgency with no control, so that's suggestive of possibly symptoms of overactive bladder. So yes, just speak to your GP.
Sorry, yeah.
I was just going to say sometimes GPs will just prescribe medication as a first line.
And if you are listening, if you hopefully don't drink too much of caffeine, fizzy drinks, alcohol, and also if you have to go more often to the waterworks and have this urgency and leak, then yes, by all means do this lifestyle adjustment and then get your GP to prescribe the medication. And obviously, if things don't get better, we're very happy to see you and try to help.
Yeah. And if you have a prolapse, should you avoid lifting things?
Lifting heavy weight is not good, because even after the operation, lifting heavy weights, because the excess for when you lift heavy weight, the excess goes through the pelvic floor and can increase your chance of having a reoccurrence of prolapse. So it's a jerky, very heavy movement we're talking about. But lighter hoovers, lighter laundry baskets, or lighter shopping, that's absolutely fine.
Thank you. A question about, can pelvic floor exercises stop a prolapse going from stage 2 to stage 3?
Yeah, I mean, after it's gone past stage 2, it's very difficult for pelvic floor exercise to bring it back. But yes, if good pelvic floor exercises can help for making it not worse in future.
Yeah.
So that's one of the really important thing which you can help yourself with pelvic floor exercises. Absolutely, yes.
Yeah. And I've been told I have a retroverted uterus. Is that significant in terms of bladder prolapse or any prolapse?
Not at all. 1 in 4 women are born with a retroverted uterus, and it doesn't make any difference to anything.
Lovely. Thank you very much. So lovely. Thank you for attending this webinar. I'm really sorry if we didn't answer all of your questions, and there has been some that we haven't managed to answer. But if you provided your name, we will answer via email. Move to the last slide. Thank you. Is that the last? Lovely, thank you. So as a thank you for joining this session tonight, we're offering you 50% off the value of a consultation for a limited period. You will get a call back from a dedicated private patient advisor and an email with a recording of the webinar, treatment information and loyalty reward points. We'll also give you updates on new and future events. We would also be grateful if you could complete the survey at the end of the session to help us shape future events. If you would like to discuss or book a consultation, either with Mr. Gupta or with the specialist nurses, our private patient team can take your call until 8 p.m. this evening, and the number is there on the screen, or if not, Monday to Friday between 8 a.m. and 6 p.m. We have a number of upcoming webinars, including acid reflux, cataract surgery and orthopedics. So please feel free to sign up to anything that you find interesting. So on behalf of Mr. Gupta and the team here at Benedon, I'd like to say thank you for joining us today, and we hope to hear from you very soon. Thank you very much. Bye-bye.
Thank you.